Good afternoon, everyone. I'm Stephanie Maselli, a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us today for a webinar for the recently released report, Temporomandibular Disorders, Priorities for Research and Care, and I have been practicing that tongue twister for weeks. The slides and recording of this webinar will be available by next week at nationalacademies.org/TMD. Again, that's nationalacademies.org/TMD. At that link, you can download the report and related resources. You can also follow the social media conversation at #TMD on Twitter. And for those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the entire committee and must undergo external peer review before they are released, as did this report. I have with me today several members of the committee that wrote the report to discuss their findings and conclusions. And before I introduce them, I want to go over a few reminders. Please note this webinar is scheduled to last 1 hour. We'll start off with a presentation summarizing the report by the committee members, and then we'll open it up to Q&A. You can simply click the Q&A button at the bottom of your screen to submit a question. And if you have any technical issues during this webinar, you can contact Zoom technical support at 1-888-799-9666 and select option 2. And now I'd like to introduce the members of the committee that wrote the report who are here with us today. Firstly, we have our chair, Kata Bond, who is President Emeritus of Burroughs Wellcome Fund and founding partner of QE Philanthropic Advisors. We have Sean Mackey, Vice Chair of the committee, who is Chief of the Division of Pain Medicine at Stanford University Medical Center. And we have committee member Corey Resnick, who is Assistant Professor of Oral and Maxillofacial Surgery at Harvard Medical School. And with that, I'd like to turn it over to Dr. Bond to start the presentation.
So welcome, everybody. We're delighted to have so many of you participating in this webinar because I think there are a lot of stakeholders who have a role in really helping us move the agenda that we have sort of developed here as a result of this study. As you can see, we had a very varied, wonderful multidisciplinary committee. Next slide. Next slide. Next slide. We had really a very complete, I want the statement of task, please, back. No, we're moving in the wrong direction. We need to go backwards. There. So we had a very complete statement of tasks, a lot of work to do. We were asked to address the current state of knowledge regarding TMD research, education and training, safety and efficacy of clinical treatments, and the burden of costs associated with TMDs. As you can see, we had to review the public health significant, evaluate the evidence base, identify barriers to appropriate care for TMD. We had to review the state of science and identify opportunities and challenges for development, dissemination, and implementation of safe and effective clinical treatments, the scientific disciplines that were needed, and identify research approaches necessary to improve the diagnosis and treatment of TMDs. Next slide, please. Next slide. So we started last January, and here we are today with report dissemination. Next slide. One of the most remarkable things in the conduct of this study was really the very eloquent input we received from individuals with TMDs and their challenges that they face. A lack of coordinated care and abandonment, overtreatment and harmful treatment, a massive impact on their quality of life, financial burden with often out-of-pocket costs, challenges in identifying qualified healthcare professionals, and the fact that they were living with multiple comorbidities. Next slide. So the findings that our committee came to is that TMDs are a set of diverse and multifactorial conditions. They're really very highly prevalent. One estimate was that nearly 5% of U.S. adults had pain in the region of the jaw that could be related to a TMD, and that they have significant public health impact. Next slide. These diseases have been compartmentalized as a dental issue for way too long. There is a massive divide between medical and dental care here in the United States, and this profoundly affects care systems, payment mechanisms, and professional education and training. We support a biosocial model of TMDs that's interdisciplinary and that can be used across medicine and dentistry. We found that there are still outdated and non-evidence-based beliefs about TMD therapies that have been and continue to be harmful, and we believe that evidence-based clinical practice guidelines are sorely needed, as well as efforts to enhance accessibility to high-quality patient-centered care. Next slide. So we developed a set of action areas that I'm going to ask our committee members to go through, and then I'll come back to the recommendation 11. So there were 4 action areas: build and sustain collaborative and multidisciplinary research, which Dr. Mackey is going to go through for us, and then improve access to and quality of TMD healthcare, which are recommendations 5 through 8, and then we'll turn to improving healthcare professional education about TMDs, which Dr. Resnick will take, and then I'll come back to raise awareness. So take it away, Sean.
Great. Thank you, Kata. And thank you all for joining today and supporting this important effort. I've been honored to work with this truly incredible and internationally renowned group to bring you this report from the National Academies. As a physician, scientist, and educator, I have cared for many people with chronic pain, including TMDs, and I've unfortunately seen firsthand how this condition impacts patients as well as their families and their entire community. And I'll share that our entire committee is hopeful that this report is going to be impactful and be a document for action. And as you're going to hear repeatedly, it's going to take all of us working together. So I'm now going to walk you through some of these recommendations on research and healthcare before turning it over to Dr. Resnick. Our approach, which I'll preface, our approach to these recommendations across research, healthcare, and education was to be both visionary by describing a desired future for our triple missions, but also to be strategic. Strategic by having specific objectives, timelines, measurables, and stakeholders. We specifically tried to avoid boiling the ocean, if you will, but instead to define recommendations that are both achievable and also impactful, particularly impactful for those people suffering from TMDs. We were also guided by the Institute of Medicine Pain Report, the National Pain Strategy, and the Federal Pain Research Strategy. This first document, the IOM Pain Report, being this high-level blueprint of chronic pain, the NPS and the Federal Pain Research Strategy being more implementation-based. And as such, there's consistency across our recommendations and the goals, messages, and implementation approaches across all these documents, meaning that if we implement these recommendations, they'll have additional benefit of addressing chronic pain in general and also taking a bite out of this current opioid crisis. So let's dive in and start with the research findings. There were 3 main bullets that we put forward in these research findings. The first being that despite the fact that we've invested much and we've advanced scientific knowledge on the research of TMDs, we still have yet to unravel many of the etiologies, the pathophysiologies of TMD, and then to take that knowledge and translate it into safe and effective clinical practice. Secondly, what we learned is that it's going to take all of us, multiple stakeholders are going to be required to look at this problem from different perspectives. And the problem we have is that we're all, in many cases, existing in individual silos that are keeping this research isolated and not communicating collaboratively. And so after identifying those multiple stakeholders, we need to bring this together in a team science approach, an organized research approach to bring together public and private stakeholders to focus future research efforts that'll fill these key evidence gaps, and then to ensure that these findings are translated into patient-centered outcomes that are prioritized. Next slide, please. In that third bullet point that I mentioned before, where we need a coordinated approach to coordinate an organized approach, the first recommendation is to create and sustain a national collaborative research consortium for TMDs. Now, I'm not going to read off all of these small bullets here. They're there on your screen for you. But it crosses everything from identifying what are the research questions to take after, building that infrastructure, establishing key metrics, facilitate interdisciplinary collaborations, as well as public and private partnerships. We did identify as major stakeholders the NIH Office of the Director, as well as NIDCR, that should take a leadership role in establishing this research consortium for TMDs. And we've put forward more of the details about exactly how to do this on the report itself. Next slide, please. The next three recommendations, 2, 3, and 4, take us from researching TMDs from, if you will, cells to society. So recommendation 2 is to start with the basic science research and translational research. We need more fundamental research about the mechanisms and pathophysiology of TMDs, and it's going to require bringing together again those multidisciplinary team research approaches that are going to fill those evidence gaps that we can then take into, by the way, research 3, which is to strengthen population-based research. In other words, we need to better understand the incidence, the prevalence. We need to better understand what are the costs associated with this, what works and for whom, and we need to improve our data collection and assessment and dissemination of this knowledge. Recommendation 4 is to take all of this information and then bolster clinical research efforts to build the evidence base for patient-centered TMD care and public health interventions. In other words, this is, in essence, the implementation aspect of this, where we need to translate that information directly into a safe and effective treatments that improve the quality of care for people with TMD. Next slide, please. Pivoting now to healthcare. So there were 5 main principles here that we built upon. First is a recognition that despite significant amount of research, there's ultimately a minimal amount of high quality data that can be used to help guide our clinical decision making, particularly in defining what is the best treatment for the right patient in front of us in their specific circumstance. We put forward that self-management and patient education are important components of care with TMD, and particularly for those patients or people living with TMDs on the line, I want to be careful in defining self-management here. It means, in this case, to give people tools to better empower them to help care for their particular condition and their overall health. It also does mean more formal types of self-management involving, for instance, behavioral medicine approaches. We also recognize that physical therapy can play a significant role in improving pain and functional outcomes. One of the key messages here was to try to avoid harm. And we picked out this area of occlusal adjustment and equilibration for TMDs, in which the committee reviewed the available literature and found that not only was there not good data, the data that was found showed that these really are not effective at all, and that we should be dissuading people from doing more of this. We recognized that we need better evidence-based clinical practice guidelines, and we need them from trusted sources. And where the evidence is not available, we need trusted expert opinion guidelines to complement those evidence-based clinical practice guidelines, and we need to get those disseminated. Finally, we recognize that payment or insurance coverage for TMDs is not consistent, and that frequently we tend to incentivize the wrong things. To borrow a phrase from my former dean, there are perverse incentives that tend to cause people to do the wrong thing to patients because they are better covered, and not to engage people in low risk but more effective treatments because of, again, lack of insurance coverage, and we'll get to that. Let's dive into those recommendations now. Recommendations 5 and 6. Next slide, please. Recommendation 5. Well, let me start off by saying that we were guided by several basic principles in this effort. One was to be patient-centered. We heard from numerous people who have been suffering from TMDs or their caregivers, and we took that to heart. We listened carefully, and we shaped many of these recommendations to address their needs. The second is that we need a coordinated multidisciplinary approach, that we need multiple people, once again, working together and breaking down silos. And the third is the cornerstone upon which much of this is built, which is education. So diving into recommendation 5, we need to improve the assessment and risk stratification of TMDs to advance patient care. In other words, we need better diagnostic tools, better assessment tools to guide primary care docs, dentists, to know what are the right treatments for patients in their clinic, but also when to make referrals to specialists as needed. We also developed recommendation 6, which once again, we noted that there is significant existing knowledge out there that can help guide better quality assessment and care, but we need to get it into people's hands. So we need to develop and disseminate evidence-based clinical practice guidelines as well as quality metrics for TMD care. We need these guidelines to be both developed based on evidence as well as expert opinion, and we need to get them widely disseminated so that we can get this information in the hands of people who are treating these people, from the primary care dentists and clinicians all the way to the specialists. And we also need to measure the impact of those guidelines. Next slide, please. Recommendation 7 is addressing the money. We note that there is a divide, a separation between how dentists are typically reimbursed for the management of TMD from those of us that are physicians. And even, well, let's say, first of all, that we need to address that divide and we need to improve reimbursement across the entire clinical playing field and bring some parity and equity to there. We need to make sure that the dentists are getting appropriately reimbursed to care for patients with TMDs, but also that both groups of physicians, both groups of clinicians are being appropriately reimbursed to do team-based multidisciplinary care, neither of which are occurring right now. Finally, recommendation 8 is to develop centers of excellence. We recognized that we need to have these defined centers of excellence for clinical care, education, and research that can serve as bases upon which fundamental research and comprehensive clinical care and education can be delivered, and then from those centers to disseminate that knowledge out to the rest of the country that everybody can benefit from. So with that, let's turn our attention to professional education that will be taken by Dr. Resnick.
And Kata, and thank you to all those that have joined this webinar, as your interest in this field really helps propel us toward improved care for our patients with TMDs. So this is very important work. On to the next slide about professional education. It became apparent in our committee's discussion, and particularly informed by listening to many patients who have suffered for generations and decades with TMDs, that ineffective and potentially harmful treatment is still commonly used by dentists and many other practitioners, even after some knowledge has improved in our care of TMDs. We think that this is a result of poor collaboration amongst different specialties, that divide between the dental and medical practitioners that Kata mentioned in the findings of this report earlier, and inadequate training in the fields of temporomandibular disorders and orofacial pain across different disciplines. I do want to emphasize, though, that despite the findings of these gaps in education, we also did identify that many practitioners and centers have made excellent progress toward improving comprehensive care of TMDs and orofacial pain, toward improving the multidisciplinary collaboration, breaking down some of these dental and medical divides, and improving patient outcomes. And so in addition to calling for improvement in education for others, we also would like to support and expand those ongoing positive initiatives. Next slide, please. So those findings led to these recommendations 9 and 10 that you see here, which focus on improving education and training with regard to TMD care and orofacial pain. And our committee has called for addition and strengthening of TMD education ranging at all levels, all the way from graduate school education to postgraduate levels and residency and fellowship training. And also to involve all relevant health professionals. Prior to this, much of TMD education has been in dental schools or in dental professional programs, but we really think that it's important that not only is that strengthened in the dental education system, but also expanded to other important providers, including medical physicians, primary care doctors, physical therapists, nurses, and others. And we also recognize the importance of increasing the number of TMD providers that are being trained, not only the quality of their training, but the ability to be able to find TMD providers to improve access to care for patients in need. So back to you, Kata, to discuss the awareness and stigma of TMDs.
Thank you, Corey. So the next slide. So as we conducted this study, we tried to derive several key messages for the general public. There's very low awareness about TMD in the public, and also patients who experience TMDs are stigmatized. And so it's very important, we feel, to communicate that not all TMDs are the same, that as a first pass, we should avoid harm. We need to explore a variety of options for care, that patients should be empowered to ask questions and seek person-centered care and get multiple opinions, and that unfortunately at this point the knowledge base underlying the biology of TMDs and the care of patients is still in its infancy, and I think patients need to know that. Next slide. So as a result of sort of those findings, our committee wanted to recommend raise the awareness, improve education, and reduce stigma, that we need to develop a set of tools and patient-focused tools, particularly related to TMDs, that they should be strengthened, promoted, and widely disseminated through many avenues for adults and youth of all health literacy levels and in many languages, in order to really raise the burden of this is very large, as we found, but we need to raise public awareness about TMDs and to improve the resources that are available to patients and families and reduce the stigma related to TMDs. And the next slide, as we've said throughout our conversations with you, really it isn't just that one person needs to be involved. This is going to need us all working on these issues. Patient advocates have already brought this issue very much to the fore, but we still need them, and we need patient-focused organizations to continue to work on this issue and move the agenda. We need the work of healthcare professionals across many areas of dentistry, health, and medicine to become aware and move the agenda. Research funders and researchers need to be engaged in moving the agenda. health professional associations and organizations, in many cases, we need their help in raising the status of people who work on this issue and developing the guidelines that we need in this area. Healthcare professional schools are obviously needed in their roles in educating these clinicians, and we need healthcare systems, both private and public, dental and medical insurers, to really adopt many of the recommendations that came out of this report. Next slide. So moving forward, key to making a difference in improving care for individuals with a TMD will be pioneering pathways that bring together medicine, dentistry, physical therapy, and other fields of healthcare to provide that holistic, comprehensive approach to care. And here, we really need interprofessional and interdisciplinary efforts are of critical importance. We need a willingness of healthcare agencies, organizations, and professionals to commit the resources that are needed to address this long neglected and often dismissed area of healthcare. There are really not enough resources going into this area. And when we went up to help have we brief one of the senators, we made this case very openly that we need more resources in this area. And we need an openness and commitment by all to using and strengthening the evidence base on TMD treatment and changing practice as needed. We have some information that can inform the development of clinical guidelines, but we need much more resource to develop the strong knowledge base that we need in this area. So with that, I think that's the last slide, isn't it? The last slide. Is there one more slide? So thank you. This is the public release. We have dissemination materials, and there is a free PDF of the report available. So with that, I think we can open the floor to questions.
Yes, excellent. Thank you, Dr. Bond and team. So our first question is, given that patients arrive at a diagnosis many different ways, be it general dentist, primary care doctor, physical therapist, another provider, what is the committee's vision for the ideal patient journey?
So why don't I ask Dr. Mackey and Dr. Resnick to begin the conversation on that question.
Certainly. Thank you, Kata. So we think about the approach to this in somewhat of a step care model. In other words, we recognize that the vast majority of people with TMDs are probably managing it at home. And what we want to do is further empower them in their management so that they're better informed, they're better able to take care of existing resources that are available to them to make an impact. Now, the next step along that step care model is to engage at the primary care level, and that's going to be with your general dentist or your primary care clinician. And our goal there is to empower those clinicians to be better informed. Again, you're hearing education is the cornerstone here on how to assess and treat the person with TMDs. Now, let's say that that particular person's TMD situation is rather complicated. Maybe they've got other chronic pain issues. We need to better inform those primary care clinicians on when is the appropriate time to make a referral to a specialist or even a multidisciplinary team of people. So that's the vision for where we need to be. Are we there now? No, of course not. We need to build that model, and that's where it's going to take all of us collaborating.
Corey, do you want to comment? And then maybe Penny, you might want to say something from the perspective of the patient.
Yeah, thanks, Sean. That was a great summary of the step care model we proposed. And the only things that I would add are that in addition to increasing the education both of patients with TMDs and of their care providers we'd also like to increase resources that are available for care providers to give to patients, resources on how to find other treatment options like self-care, and give patients the empowerment to know where to find clinicians that have knowledge about TMD care, and also how to escalate their treatment into centers of excellence when that's deemed necessary, either by the patient or by the clinician. So we'd hope to increase both education and resources for this problem across the board.
Penny, do you want to speak from
Sure.
your perspective?
Sure, and I think one of the things people with TMD that are dealing with it know that it really doesn't just affect the head, it affects the whole person. And what we want to do is to provide hope, not only to recognize that TMD is a public health problem, but to let them know that they need to take advantage not only of the treatments, but of the support of patient groups and advocacy groups that are out there, people that are actually living with these, to be able to get that support. I think it's really important to know that you're not alone, that there's someone out there who really understands what you're going through. In some sense, that gives them validation, and it hopefully gives them some hope.
Another question?
Excellent. Can you summarize the key research priorities, both short and long term, that must be addressed?
Kathleen, can you start that, and maybe Sean too?
Right. So the research, I'm unmuted. Okay. The research priorities that we discussed are really very diverse. We're talking about trying to really uncover the pathophysiology and the etiology of what factors are contributing to it at a real basic level, what molecular mechanisms are involved in the generation of this, all the way to improving patient care and implementing those guidelines. So the big weaknesses we found were really and I wouldn't even say there were so much as weaknesses, is where we are going with research is some more broad-based kind of large-scale clinical studies. They're doing translational work, looking for biomarkers, looking for factors. That's one area. Looking at better animal models that really integrate across the discipline and mimic temporomandibular disorders from multiple perspectives and seeing what overlap we have. And then coming up with some really high-level, high-quality clinical trials that can help to inform our evidence-based guidelines at a better level. Things wrapped around non-pharmacological as well as pharmacological treatments. There's been a wealth of data on pharmacological treatments and some surgical interventions, but we haven't put as much efforts into self-management and into some of the non-drug treatments that are out there for individuals with temporomandibular disorder, with the hope that we'll get some better quality evidence. So it's really very, very diverse and very translational back and forth to try and understand how people are developing chronic pain, as well as how are we going to move forward with the treatment of those who do have it.
Kathleen, well stated. Just to build three things on that briefly. One is we have been guided significantly by the incredible work that was done by OPERA, supported by NIDCR. And they've really laid the groundwork for understanding better some of the mechanisms of TMDs, the role that TMDs have in this concept of chronic overlapping pain conditions, and how frequently TMDs are co-occurring with these other pain conditions, and many of the basic and translational research. But we need to build on that. And in making our recommendations, we were guided by those from the Federal Pain Research Strategy, as well as the National Pain Strategy. And I would encourage the audience to look back on those, because we find that many of the basic, translational, and clinical research recommendations in the Federal Pain Research Strategy applied part and parcel with our report. And similarly, in the National Pain Strategy, the population research recommendations finding the prevalence, the incidence of these conditions, what works for whom and why and at what costs. They overlap significantly with our recommendations we put forward in TMD. So there is beautiful synergy between all of these documents.
Bob, do you want to also add to that, since you had a role in sort of looking at some of the data?
Sure. We, looking at sort of national level data and large study data, found that we were dealing with a variety of different research methods, case definitions, et cetera, which led to a very sort of confused literature. And I would think that sort of arriving at an underlying research methodology that people could agree on would help inform future research. And in so doing, allow us to really reach an understanding of risk factors and prognostic factors, which I think at this point we have some sense of that, but it really needs more clarity. So I think that we need to get those methods solidified, and then we need to put them into the field in sort of an ongoing surveillance model or an ongoing way, using things like the National Health Interview Survey or the National Health Examination and Nutrition Surveys. So those types of studies, I think, would benefit from better methods. I also think that, as we had heard earlier from Sean, there are some perverse incentives out there, and the perverse incentives result in people providing care that's either ineffective or, in some cases, harmful. So I think we need health services research to feel how we would better structure the whole healthcare delivery system, with an emphasis on how care is financed, so that we get clinician behavior that is consistent with best evidence and leads to the optimal outcomes.
Thank you. Next question.
Because you are recommending a TMD specialty within the ADA, where are you proposing the joint pathology, pain and non-pain comorbidities, and multiple body systems illnesses be addressed?
Okay, well, I think Dr. Resnick, Dr. Wynant, and Dr. Mackey can probably talk to that issue.
Sure, this is Corey Resnick. So we are in support of the recognition of TMD care, or orofacial pain as it's usually called, as its own specialty. And we think that that would actually promote rather than detract from the ability to take good care of patients with other comorbidities that may not be totally painful, because this would really promote the education and knowledge around temporomandibular joint function. It would help support the research agenda that we just discussed, and it will create an environment where a group of clinicians are always at the highest level of knowledge about how the joint functions and the pathology that may occur with it. So even though the specialty is often focused on pain, I think this would really promote the level of care for even patients with temporomandibular problems that aren't painful and other comorbid conditions as well.
John, you certainly have some experience in that. You want to speak to that too?
Yeah, I think it comes down to the simple fact that people are not joints, that we need to look at the whole person, and that the fact that these temporomandibular disorders impact the whole person, and as such, we need people with different levels of different types of expertise coming together to address all aspects of the biological, the psychological, and the social aspects of these conditions, and that's going to take a multidisciplinary team.
Bob, do you want to add anything there?
I think as we looked across the dental education models that we looked at, that it was clear that there's a fair amount of heterogeneity in what's being taught across dental schools, and anything that would support developing a consistent evidence-based curriculum. And I think movement toward a specialty would certainly provide that impetus. So I think there'd be a good rationale for doing that, just as generally improving dental education.
Kata, would you mind if I added a moment?
No, please do.
So, this is Kathleen Floka, and I wanted to just kind of expand on what Sean brought up about the localization of TMD and that it goes beyond just the person. It's become increasingly clear that not just for TMD, but for almost every other pain condition out there, whether it's osteoarthritis or knee pain of some sort or back pain or shoulder pain, very few percentages of people, less than 20%, tend to have pain in just that one spot. And most of them are having pain in multiple areas. And treating just one of those areas does not get the person to the next stage. So we have to have a better education and specialists across not only the knowledge about temporomandibular disorder, but about pain in general in order for patients to be adequately treated and to move forward in the healthcare system and make real results. And that has to be done at multiple levels of education, from having specialists who can serve as resources to practicing dentists, to having the practicing dentists get better education within their own dental school, as well as the physical therapists and the physicians having that broader understanding. And this all is in line with the National Pain Strategy as well.
Yeah. Penny, do you have a viewpoint on that question?
Yeah, I do, because what I've heard is how the professionals need to, be better trained, more aware. But I think that it's a team approach, and without the person with pain at the center of that and taking some of that responsibility rather than being a passive patient, become an active participant and understand what their role is in the care as well. Like going to physical therapy, if you just go to physical therapy and you don't follow through at home. So I think it's important that when we're looking at any kind of treatment, that we make sure that the person with pain is really a part. They're an active participant in that care, and they share in the responsibility, just not looking to healthcare professionals to make them better, but that they're part of it and they're working toward the same goal.
Thanks. Is there another question?
A listener just wrote in, can you name a patient focus group? I have yet to find one.
Oh, well,
Penny?
That sounds like a Penny question.
There are several.
Yeah, there are several. I think that probably the best ones for TMDs are the TMJ Association, and they have an amazing website. We've heard nothing but good things about that. That they really are very supportive, very educational. That would be the one I'd refer to. I also have one, the American Chronic Pain Association, which also provides a lot of self-management education and empowerment to help people become that active participant in their healthcare, but also to provide that support knowing that they're not alone. There's a wealth of resources out there. If you go on either of these websites, I think you'll be able to find all the resources that you need, or you can just, send an email and they'll get in touch with one of us, I'm sure, if you want to know how to contact us.
There are also some good materials on the NIH web, too. Yeah. Another question?
Thank you. The report mentioned harmful occlusal adjustments. Did you address the use of splints or appliances?
Bob or Corey, you want to take that one?
I'll throw it to Corey if he's comfortable with that.
Sure. We did address that, and I think we tried to take that on fairly head on in that we went through treatments that are currently available and currently used and the evidence base for them. Of course, many treatments that are often done have either no or very little evidence, but there aren't a whole lot of treatments that actually have some clear evidence of harm or complete ineffectiveness. And some of the occlusal treatments fall into that rare category where there's real evidence to suggest that they're either not helpful or sometimes harmful. In many cases across the board, some other treatments certainly can be used inappropriately but aren't harmful to all. So we really did mention that one head on and talked about some of the barriers to eliminating some of these ineffective treatments and some methods to improve education of providers to try to stay away from treatments that have negative or ineffective evidence like that.
Next. Or Bob, do you want anything, or good?
No, that's exactly the right answer.
Yeah. Next question.
What are your recommendations for stopping the harm, physical from treatment, psychological, and financial, being done to patients now?
Clinical practice guidelines?
Yeah, that
would be a good start.
Go ahead, Bob.
Yeah. Go ahead, Sean.
Well, we're going to come back to the clinical practice guidelines you mentioned. I think in part to help remove some of the incentives to do that. So once again, if we can better incentivize clinicians to provide the best quality care, the best team-based care, that will probably help in a great way to change behaviors. And then back to you, Bob, on the kind of the education and the clinical guidelines.
Yeah, I think what we know is that one of the first people that are likely to be seen by somebody who's developing symptoms of a TMD is a primary care physician or a primary care provider of some sort or a dentist. And if those clinicians have in their hands clinical practice guidelines that help them go through a proper assessment and understand when there are, very early interventions, conservative interventions that could be tried, and then when it's time to escalate and refer the patient. So if those guidelines can sort of sort out that process for people, I think that's going to go a long way to eliminating some of the inappropriate treatment and getting people started conservatively and moved along as needed. And I know that that's going to be a huge supplement in the dental domain because a lot of dental schools are not really teaching this currently. So having that for existing clinicians would be quite helpful, I think.
Yeah, and this, Corey, and I would just agree that improvement in the research and education of how to provide effective treatments will certainly help us eliminate the ineffective ones. But I'd have to emphasize what Sean said, that while the incentives for providing care are misaligned, and insurance coverage sometimes allows the provision of ineffective care and not effective care, until those priorities are aligned properly, it's very hard to change clinician behavior.
And I would add that it goes also to the patient. So currently, if you get a pharmaceutical agent, it's relatively inexpensive. If you go to the physical therapist, you're paying a copay every time you go. And you have to do that 2 or 3 times a week, and that can add up to a substantial amount of money. So not only realigning the pay incentives for the healthcare professionals, but also the incentives in making it an easier choice and affordable choice for the patient to make, to do the safe, less risky treatments first and make those choices.
Good. Next question.
Comorbid conditions are a big issue with many TMD patients. What focus will be placed on this?
Sean, do you want to tackle that one?
Yeah, there is.
Others chime in.
Sure. There's been growing recognition from the efforts such as OPERA, from the other NIH multi-center effort MAP, as well as many other researchers out there who have identified that many of these chronic pain conditions that exist out there, TMD, back pain, headache, you name it, they don't exist in isolation. That in fact, they co-occur with each other with very high frequency. And on top of that, that when they do co-occur, when you have somebody with TMD and back pain, for instance, they tend to have more likely high impact chronic pain. And so we need to focus tremendous attention on the clinical care of these patients and recognizing that once again, this person is not just a joint, that they may have other painful conditions that co-occur, and we need to address those in its entirety. And then similarly, on the research side, recognizing that many of these conditions probably have shared mechanisms for their development of the chronic pain, but also the persistence of it. And so that, once again, we're coming back to, it's going to take a team of clinicians and a team of researchers to be able to most effectively address this issue.
And this is Corey Resnick. I would add that this is another area where the Center of Excellence model can be incredibly helpful for the patient with a complicated TMD that has comorbidities, because that's a scenario where there may be additional resources from multiple types of care providers to help inform the treatment decisions that might be based on those comorbidities. A Center of Excellence should have the ability to call on rheumatology services, for instance, for a patient with an inflammatory arthritis that's a contributor to their TMD, or other specialty care providers that can help manage the patient with these comorbid conditions in a more comprehensive way.
And I would just add that we have spent a significant amount of time talking about this and understanding this kind of comorbid conditions that occur with TMD, because it really has become increasingly aware across almost all chronic pain conditions that this is an issue. And even at the basic science level, all the way through translational research levels, we're really talking about an interdisciplinary approach beyond just the physician and the physical therapist, but thinking about bringing in certain molecular biologists and biomechanists and certain other disciplines really at a very basic level to try and look at this from with an open eyes perspective to see if we can help with the understanding of how we're even getting these in the first place.
Well, one of the things that I found, this is Kata, was that we really would like to have that knowledge base so that we could really apply both primary, secondary, and tertiary, preventive approaches when patients, first of all, to prevent it altogether, but then if you've got it, to whichever one you have to prevent it progressing, and then if you have it, the appropriate approaches to really caring for the individual and at all these levels. So, and it's not just one disease, of course. There were at least over 30 different conditions that are TMDs. Do we have another question?
Thank you. You are largely emphasizing the pain aspect of TMDs, but overemphasis on pain may discourage the needed scientific efforts to reveal the underlying causes of this pain. Please comment.
Who wants to comment?
I'll start. This is Kathleen.
Good.
And we actually, within the research section, and if you can go into that section, you'll see that we spent a considerable amount of time talking about the biomechanical aspects of it, about the things that were happening and what the differences are between the tissues at the site. And while we are talking a lot about pain, maybe that's primarily because I'm a pain researcher and Sean is a pain researcher, we didn't completely ignore it. And we actually think that it's probably a multifactorial cause and etiology, that maybe some of it is biomechanical, but some of it will also likely be something that's changed in the central nervous system or the peripheral nervous system in how our body is processing the injury or the pain itself. And so we think it's probably going to be that, and we actually called for a better integration between those people who are studying pain and pain mechanisms and etiologies with the people who are studying the biomechanical and the joint and the tissues and what's happening at that level, because we think those people probably need to talk together to really come at a broader perspective of a model. So I do understand where you're coming from, and I think we've probably not done a good job of explaining that those research priorities have gone deep into that area as well. And I do think you can take a look at what we said in there, but I do think it's a very important point that you bring up. So there's kind of multiple factors. that we're
Yeah, I would
looking at.
say, Kathleen, this is Kata too. One of the surprises to me was how complex that particular joint is and how little we know about it in comparison to other joints. And the fact is that it has a great deal of differences with other joints that really need to be explored and studied further.
Yeah.
Thank you. The next question is, do we have adequate data systems to monitor progress in treating or preventing TMDs?
No.
Bob?
Yeah,
No, but Bob.
I'll second Sean's. That's a big no. Yeah, I mean, there's data systems at all levels. Like, are you talking about sort of interoperability of medical records and dental records, or are you talking about epidemiological? In both cases, the answer is no, but there are certainly different levels at which the data issues need to be addressed.
Yeah, there was strong parallels here with what we found in the National Pain Strategy and called for in the Population Research Working Group, in that we need to, one, better identify the best outcome measures to measure. We need to integrate those outcome measures into our electronic medical records, into our research databases, into our large national databases, so that we can get you the answer of how many people out there are impacted by TMDs, what's the cost to the individual, what's the cost to society, which treatments work for whom and for why. And there's a clear need for high quality data that is actionable. And we called for that directly within this report.
Another question?
Thank you. And it looks like this will be our last question. I know we're coming up on the hour. To implement these recommendations, it'll clearly take some time. So what can a patient with TMD do now to head toward relief?
Well, I think follow I think there are a variety of things that patients can do now. I think we tried to put out some messages about do no harm and ask questions and empower yourself to seek the best care you possibly can. I don't know, Penny, do you want to add into that?
Yeah, and I think you're right. I mean, you really need to educate yourself, knowing that you can get more than one opinion, but you have to be the one to make that decision on whether this is right for me or not. And that's why it's so helpful sometimes to go to these peer groups, to get information from other people, hear their experiences, their recommendations, and then find a provider that you actually can work with and trust. But I think we've heard throughout this whole last hour is that it's multi-system. There's many different components. So you may need to check both with your primary care as well as your primary dentist and begin that journey there. But the bottom line is, remember, write your questions down, ask them, and make sure that you get answers for them so that you can make informed decisions. And if you're not comfortable, do more research, get more information so that, again, you know that when you're making that decision, it's the best one for you.
Anybody want to add to that? Well, I would just want to say thank you to our audience. This has been quite an odyssey. We've all learned a lot in the process. My hat is off to the patients who really participated, and I hope all the stakeholders will help us in moving this agenda forward.
Thank you, Dr. Vaughn, and to all the committee members who joined us today. And if we didn't get to your question, I apologize. We had several hundred people join today's webinar, but once you exit, you will be redirected to our report page. And again, that's nationalacademies.org/TMD. You can download all the resources there. And once again, I'd like to thank you all for joining us this afternoon.
Bye.
Thank you all.